Okay, so I have been collaborating with neuro-oncologists to look at quality of life in brain tumor patients. And it has been, I think, the issue of sexual function has been, okay, oh, there we go. Okay. Because treatments are being developed that are effective, many people with different types of cancers are surviving longer, for even decades. And so now quality of life has become an important factor for patients and for healthcare providers. And this extends into multiple domains of life. If you look at quality of life instruments, they cover a whole range of topics, including having a sense of well-being in the physically, but also psychologically, socially, and spiritually. And in fact, the American Medical Group, who provided a document on quality of life and survivorship, have argued that it's important to provide information to patients about the effects of their cancer and its treatment on their marital or partner relationship, on sexual functioning, as well as the other typical things you might think of, like work and parenting and so on. The difficulty is that there's very little work done on understanding what happens to people's sexual function when they get diagnosed and treated for brain tumors. I did a search of PubMed using sexual function and brain cancer terms and found very few studies. Most studies answer simple questions. The quality of life surveys typically have one question: are you satisfied with your sex life? And they often give the researchers, the patients, the option to actually skip the question. And so the information just isn't getting gathered. The other issue is that some tumors get more attention. Some forms of cancer get more attention in terms of sexual function. Obviously, cancers of the reproductive system, prostate cancer, ovarian cancer, uterine cancer, breast cancer, and so on, get a lot of attention. In terms of the brain, most of the research that is looking at this is focused on the pituitary tumors, and that's kind of for obvious reasons, because of the hormone, the role of pituitary in regulating sex and other hormones. And in most of these studies, there's not a clear separation between the tumor itself and the treatment of the tumor. And it's probably the case that there are different effects of these things. Just to give you an example of the kinds of studies that have been done, one study, you had 32 patients with low-grade gliomas who had surgery, and about half of them had postoperative sexual changes. They, however, used something called an Arizona Sexual Experiences Scale, which is not, as far as I could tell, a widely accepted standardized scale of sexual function. And it only had 5 items that covered both male and female sexuality. So it's a pretty limited. It was a little more than, are you satisfied, but not a whole lot much more. And then Finocchiaro published in 2017 another study looking at 46 patients. And again, about half of the patients reported sexual disturbances. They also found high levels of anxiety and depression and a poor quality of life. And these authors actually asked about the patient's interest in getting information about sex and the changes that might happen. And they were, but only 15% of them actually got information. And of those, very few of them actually asked for the information to get it. So people want to know, but providers aren't giving information and people aren't asking for it. So it's a challenging area to help patients in. And of course, the first thing we need is a whole lot more information about what what are the effects of brain tumors and their treatment on sexual function. So what we see basically from the literature that I've looked at so far is both men and women have a high rate of sexual concerns. The studies of pituitary adenomas, men have a high incidence of sexual dysfunction, which is usually things like erectile dysfunction. Sexual function tends to be higher among women than men and tends to be more in the domain of desire. But it seems that all of the areas are affected. And so these studies have been not utilizing the standard validated measures. And so what we wanted to do was actually look at this more systematically with better instruments so that we could really tease apart what's going on with these patients. So the scales we used were the Female Sexual Function Index, the International Index of Erectile Dysfunction, and the Premature Ejaculation Profile, obviously for females and males. And these are widely used in the field of sexual medicine and are well accepted as being able to assess details of sexual function. In addition, we used the FACT-BR for the quality of life, and we asked about the cancer type, the location, and the treatment the patients had received. We had 59 participants with a diagnosis at the Baylor Scott and White Neuro-Oncology program, 37 female and 13 male, and was given to understand by my collaborator that's a pretty typical sex ratio for this type of cancer. After they consented, they filled out demographics. We got cancer diagnosis and treatment. We gave them the quality of life scale, and then the females got the FSFI, and the males got the erectile function and premature ejaculation scales. We looked at the subscales of the quality of life, believing that that would be relevant to relating that to what we're seeing in the sexual function. And this scale breaks down into four: physical well-being, social well-being, emotional well-being, functional well-being, and then brain cancer special concerns that involve things like cognitive issues, sensory issues, personality changes, and so on. But you can see here that it covers a wide range of functions and subgroups them into reasonable categories. The social well-being one was primarily focused on family and friends. There was only one question related to the partner and one question related to sex in that context. And of course, the sex one, they had the option of not answering it. About 25% of our sample did not answer that question, even though that's what the study was about and they had agreed to participate, which I found very interesting. But if we look at the outcome of that for the males and females, you can see the scores and the standard errors, the means here. And basically, there were no sex differences between the males and females. They all rated pretty similarly on the quality of life measures. The FSFI has, and the erectile function scales have clinical cutoffs where if their scores are below these numbers, that represents a clinical condition that should be addressed. And so these are the clinical cutoffs for the various subcategories in the FSFI: desire, arousal, lubrication, orgasm, satisfaction, pain, and then total. And what we found was, this was the mean score over here. This is the clinical cutoff, and this is the percent of our subject population that met the clinical criteria. And this is what the general prevalence is. For reference, these are the numbers you see if you tap the general population. And what you'll notice is in a lot of these, the clinical problem, the clinical dysfunction rating is about double in our cancer population compared to general prevalence of these difficulties. So that's a pretty big difference from as a consequence of either the diagnosis or the treatment of these cancers. If we look at the female's sexual function and relating it to the quality of life measures, the social well-being scale was pretty much positively correlated with all of this. If their social well-being was high, their desire was higher, and if it was lower, their desire was lower. Now, and I made the point about that this scale only contained one question on the partner and one question on sex. The rest of it was all about families and friends and support and that kind of stuff. So the social environment generically clearly has an impact on women's adjustment in terms of sexual function in the context of cancer. The functional well-being, which is kind of the one I expected to come out more, still was correlated, but to a whole lot lesser extent, the primary one being desire, and the others were marginal at best. So it seemed that for women in particular, the sexual function compromise was related to how well they were doing in the social domain, which has implications for how the patients are helped during survivorship. We had a lot fewer males. We had only 13 males, and a couple of them were not sexually active. And so I don't have the same kinds of percentages possible for them. But what you see is, in terms of, again, meeting criteria for dysfunction, most of our males had moderate to severe erectile dysfunction, and all of them had other kinds of dysfunction, whether it was orgasmic or desire or satisfaction in general. So the males were also profoundly affected by this. And we looked at the types of cancers. The majority of our patients had glioblastoma or meningioma. And then there was a scattering of other kinds that we collapsed down into others, simply because if there were only 2 or 3 of them, it didn't make more sense. And one of the things we found, so for the women, the quality of life was related to the sexual function. For the men, it was not so much the quality of life as it was the type of cancer they got. So the men with meningiomas had significantly greater erectile dysfunctions than men in either of the other groups. So there seems to be some difference between the way men and women respond to their experience of brain tumors and their treatment. So what we've overall found was that the sexual dysfunction rate was substantially higher than previously reported, and roughly double the rates of the prevalence in the general population, which means it's a significant issue for brain tumor survivors. For women, the primary quality of life factor that related to their sexual function was social well-being, and to some extent the functional well-being. But the social well-being was a pretty big deal, which means that support is a really important component for women. For men, the difficulties were more related to the type of tumor with which they were diagnosed. That raises a lot of question about what about these tumors is causing that, because these were not pituitary tumors, so it's not just about hormones. So it'd be interesting to do further explanation with larger sample to try to understand what about these different kinds of tumors, or maybe their locations, that are affecting men like this. So some of the implications of this work, we need more information about patients' relationship function and how that relates to their sexual function. The recommendation for survivorship planning is to make sure people know, but we need information in order to provide that to patients. They do need to be informed about potential changes associated with diagnosis and treatment. That needs to be a part of their participation in the process. And the other thing that's really important is there are actually potential interventions for these sexual dysfunctions that could be used, but we don't know how they would work with patients in this situation. We don't know, they're untested. We don't know if these medical or other kinds of interventions would be acceptable to patients going through these kinds of experiences, and whether they would be effective or not. A couple of limitations. Obviously, the number of patients we had limits how far we can go with the data, and the kind, especially with regard to the type and location of the cancer and treatment. So we are hoping in the future to be able to expand the study, look in more detail, get partners involved, and actually look at the quality of the relationship in the context of the sexual function as well as quality of life. So that's kind of where we're going with the study at this point. But we think we've got some pretty relevant information at this point, even from this small study.